Thank you so much, Pharmacist Olagunju, for the presentation. Before we go to the segment of question and answers, please, we would like to invite Dr. Joseph Ole to take over the floor for his own presentation in the next 10 minutes. Pharmacist Ole, are you on?
On mute. Oh. Okay, I'm on now.
Yeah, welcome. So glad to have you.
Thank you. Yeah, it's a pleasure. Thank you very much. So I'm not going to take too much of our time. Incidentally, all of us don't have slides for this morning. I will be speaking on steady state concentration as a pharmacokinetic parameter. I hope we're all hearing me. All right. So when you talk about concentration at steady state, this applies when we have repeated dosing or continuous infusion. And because it's clinical pharmacy, I will love to make it very practical. I would love to, because clinical pharmacy is about practice, I want to move away a bit from the theories. Okay, so there are other parameters that contribute to the steady state concentration, such as the volume of distribution that we have heard so much about, and then the plasma, the dose of the drug. Okay, now when you have repeated dosing, I want to take specific example of an antihypertensive agent, amlodipine. The standard amlodipine that we have a half-life of about 35 hours. And that is why it is now given daily. So we're saying that with a half-life of 35 hours, we expect that half of the dose that we give initially will have gone out of the system in 35 hours. Let's assume it's 24 hours now because we give every day. And so studies have shown that for drugs like that, it takes about 5 to 7 half-lives. And for amlodipine, it takes 7 to 8 half-lives for you to achieve a steady state concentration. And what is that steady state concentration? Is the concentration at which the dose you are giving to patient is the same as the amount that you getting out of the system. So if I want to give a patient 10 milligram of amlodipine and I want him to be maintained on 10 milligram, all right? So if I start giving him 10 milligram every day today, he does not yet have that 10 milligram in him until about 7 days. Well, at 7 days, the drugs will have accumulated in him and that he will now be having around 10 milligram in his system, such that subsequently when we now give the dose after 7 days, is just to maintain the 10 milligram that we have achieved. Okay, so at that point, the concentration at that point is called the steady state concentration. And what is characteristic of that is that the dose you are giving the person is the dose that is leaving the system. That is when it is steady. If it's 5 milligram I'm giving the patient, until 7 to 8 days before we will have achieved an accumulation of that 5 milligram in the system. And at that, after that, subsequent doses that we give is just to maintain that dose. And what goes in is what comes out. Now, this can also apply to other drugs that we give, repeatedly, like antibiotics that we give maybe every 12 hours or every 6 hours. At some point, by the time we are giving 5 to 6 doses, we will have achieved an accumulation of the dose that we started with. So, but we can also use this parameter, the steady state concentration, to calculate a dose that you can give as a loading dose so that you can rapidly achieve that steady state, okay, that you want. But let us know the application of it here is that for antihypertensive, for instance, you cannot review You cannot give 10 milligram Dept to a patient now, and in 3 days you want to review him to see whether that dose is working or not. Are you with me? Can everyone hear me?
Yes, speak on, Dr. Ole.
All right, so
No,
the thing seems to freeze. That's why I'm...
No,
so you cannot review, okay, you can't review that therapy in 3 days. The earliest you can review the therapy is after 7 or 8 days. That is when the patient will have achieved 10 milligram dose that you are giving, or 5 milligram dose. Now, even at that, you cannot review at 7 or 8 days because you just achieved that dose in 7 or 8 days. You now want to see if that dose will work. So you give another 7 days to sustain that dose. That is why you see if you get a newly diagnosed patient today, you give him 2 weeks before you review his therapy. In 2 weeks, the first week, he will have achieved the steady state. Then the second week, the drug will have achieved the highest or maximum effect in the next 7 days, making 14 days for that particular dose of drug. So anytime that you change the dose of antibiotic therapy, you need a minimum of 2 weeks before you can review and decide whether it's working or not. Now, same thing with antibiotics. If you take Ampiclox, for example, you are giving every 6 hours. It takes about 5 to 7 doses of that Ampiclox for you to achieve the dose that you are giving. If you are giving 500 milligram, for example, so you give every 6 hours, it takes 4 today. It's until the person is taking the third dose the second day that we will have achieved 500 milligram in the system. Now we now need to sustain that 500 milligram, maybe for another 1.5 days. That's minimum of 3 days before we can decide whether Ampiclox is working or not. For a medication that is giving BD, same thing applies. You need 5 to 7 doses before you achieve a steady state, and then you need about that same time to sustain that dose that you have achieved before you can review the medication. This is the simple and practical application of a steady state concentration in pharmacokinetics. Another thing that we can use that for is to toggle the dose when the drug has a narrow therapeutic index. For example, vancomycin. You give vancomycin daily. It is expected that that one being an antibacterial, if you give a dose now, it will be very high in the system, and then it comes down and comes low. In such cases, most of the time you don't want the antibiotic dose to drop so low before you give another one, so that the organism do not develop resistance to that vancomycin. So what you can do, if you know the steady state concentration and the half-life of the drug, you can come and take a dose that is in between. For example, if we're talking of vancomycin, the regular dose is 500 milligrams. I can decide to now come and say, I do not want to go above 500 milligrams so that I don't push the patient into toxicity, and I do not want to drop below 500 milligrams so that I don't generate resistance. I can come then and give 300 milligrams, for example, and instead of giving it 12 hourly, I'll now give it 6 hourly. Now, when you do that and you do the calculation, you will find that we have come in between the half-life and the dose. And you know, at steady state, we will achieve a dose that is never lower than 500, but is never higher than 500, in between the two. So the patient will not enter into toxicity and the organism cannot develop resistance. This is the beauty of the steady state concentration. It is applicable when we have repeated dosing for a long time, that is in chronic medication like hypertension, diabetes. It is applicable when we are doing infusion to maintain a patient in a particular state. It is applicable also in antibiotic therapy. Thank you. You're welcome.
Wait to me now.
Okay.
Okay. We appreciate Dr. Ole for the presentation. Thank you so much for the intensive lecture that you gave, even though it's very brief. We appreciate you. At this moment, we'll be taking our questions, and several questions have been sent in on our chat. We have 3 questions already for. We have 3 questions for Dr. Olaiwola already, and I would like to start this segment by first taking our comments, the comments from our Prof. Professor Femi Oyewoma. We thank you so much for being on this platform. She congratulated the UITH Department of Pharmacy for a successful clinical mission and keep it up. Thank you. Okay, so straight away, there's a comment here, a question here from Saliu Session for Dr. Olaiwola. He's asking, he said, how best can we explain the mechanisms by which chronotherapy is beneficial? Talking about timing of medication rhythm. What is the link between the circadian rhythm and the administration of statins? So I hope Prof is taking notes. Dr. Olaiwola, that question is for you. There's another question here from Grace Joshua. He said, how do we go about NSAIDs that are dosed 12 hourly in hypertensive patients with comorbidities such as arthritis? There's another comment here. The anti-inflammatory drugs are most beneficial to patients during the day when they are most active. So taking them in the evening time, how beneficial can they be to the patients suffering from arthritis, bearing in mind most of the drugs have short half-lives? And then the last question from Akimbode Matthew Olajumoke to Dr. Ole on steady states. Said, my question is about steady state concentration in patients with impaired liver or kidney. How can we maintain steady state concentration at the same time avoid drug toxicity? We'll give room for the presenters to answer these questions. Then if you have other questions, you can raise up your hands and you'll be unmuted. So at this moment, I would like to invite Dr. Olaiwola to take his own part of the question. Then Dr. Ole will also answer his own question. Sir, Dr. Olaiwola.
Hello, can you hear me?
Yes, sir, we can hear you.
Now, let me take it from the last question. Maybe it will benefit everybody. And when you have a comorbidity of hypertension and arthritis, yes, it is a known fact that most anti-inflammatory drugs are short-acting. One option is to look for a non-interacting drug to serve as the antihypertensive, and I mentioned methyldopa the other time. I also remember saying that hypertensive therapy is not an emergency until you have hypertensive emergency. In other words, pain is immediate. Pain is of immediate concern. You may resolve that pain most of the times as someone who also has those two conditions and treat and manage those two conditions. I can share benefit, and the benefit is that once you use an anti-inflammatory drug, particularly the diclofenac that has paracetamol as a single formulation, I know there are many. However, let me crave your indulgence to tell you what I use. I use Rufedol, okay? And once I take Rufedol, I know very well that it will not allow the lisinopril to work. So I stay off lisinopril, for that day. And if there's a need for a repeat administration that same day, I take the Rufedol again. From experience, the arthritis clears and ebbs, takes a back burner, and I will now be able to continue with my lisinopril. Okay, because again, if you use the anti-inflammatory for long, studies have shown that it can also precipitate hypertension on its own because of volume retention and the principle by which it works, which I elucidated the first time as blocking, the prostaglandin synthesis, and those things that keep blood pressure in check at the endothelial region of the blood vessel will have been incapacitated, removed, such that continued use of anti-inflammatory drug may result in somebody who is normotensive to become hypertensive over time. So again, when there's comorbidity, you treat the one that is painful, which is arthritis first. When it helps, you continue your journey with the anti-hypertensive. Also in that case, you may now have to revert, to nighttime administration of the antihypertensive and take your anti-inflammatory drugs in the daytime. Like I said, it is not hinged on any, metal or stone jacket. It is flexible. Thank you. The one about chronotherapy, the network was fading from Salim. If you can ask again, I won't mind.
Okay.
Here's the question.
Okay. The question reads, how best can we explain the mechanisms by which chronotherapy is beneficial? That's the first part of the question. Then the second part says, what is the link between...
It again.
How best can we explain the mechanism by which chronotherapy is beneficial?
Well,
that's
the essence of all that we have been saying, because you cannot take a drug at the wrong time. If you take a drug that is supposed to be taken on empty stomach, on a full stomach, of course the benefits will be lost. So it's the old essence, the question has just captured the essence of the whole presentation. So the way to benefit, one is to know about the pharmacokinetics of the drug. Two, to know a little or a lot about the patient, and 3, to know about the circumstance, so that you will be able to know the disease-time interaction. There are some instances, okay, for instance, you want to take a diuretic. You know that you cannot take it in the evening time so that it does not impinge on your sleep. Okay? So that's one benefit of chronotherapy. You have to wait until when you can derive the maximal benefit. If you take a diuretic in the evening, it will wake you up. Most drugs for thyroid correction, or they are taken early in the morning. Okay? And you can't take it any other time. Otherwise, you lose the benefit. I hope I got near the answer.
Okay. The second part of that question is, what is the link between the circadian rhythm and the administration of statins?
Yes, the circadian rhythm dictates most of the, in fact, particularly anything that has to do with the cardiovascular system. Based on the explanation that I made, the circadian rhythm dictates what happens with chronotherapy. If the questionnaire is also listening very well, the circadian rhythm controls the cortisol disposition, for instance. So if you don't sleep at an appropriate time, we have had a lot of people say, if they recommend 8 hours, sleep 3 hours in the afternoon and balance it up in the evening. It doesn't work out that way. That belt of 11 to 3 or to 4:30, that is the only time that cortisol is tipped. I also hope I'm getting near what is the circadian rhythm, because most of the time, atorvastatin, for instance, is recommended to be taken, at night for most people. And I think it has to do, with the circadian rhythm. The same goes for most drugs that are not even, for instance, the contraceptive pill, oral contraceptive pill. If you take it in the morning, you have to continue the administration in the mornings, because at the time that the drug is pumped back into the intestine for reconjugation, the flora must be there, and it follows a time, almost a perfect timing, such that if you are taking it in the mornings, you have to continue the administration in the morning. If it is in the evening, you have to keep taking it all evenings, because if you miss one, it may happen there may be therapeutic failure. So that's the essence of the circadian rhythm. It's not only with the statins, it applies to many other drugs along the way. Thank you.
Thank you very much, sir. There's a comment here for you also about anti-inflammatory drugs. The participant says that the anti-inflammatory drugs are most beneficial to patients during the day when they are most active. So taking them in the evening time, how beneficial can they be to the patients suffering from arthritis, bearing in mind most of the drugs have short half-lives?
Yes, even when we talk of this, I've answered it in a way that you can put the antihypertensive on hold, because antihypertensive therapy is not an emergency. Has never been, because it's management. It's not an emergency. When it becomes hypertensive emergency, then all other things will have to also hold for it to have its way. So for such patients, it is the anti-inflammatory drug that should be used for that period. It's the anti-inflammatory drug that should be used for that period. But if it is, and even though inflammation is a recurrent thing, is like something that should be managed, we have seen that people can have drug holiday from the treatment of arthritis. They can actually treat arthritis, have a succor for them to continue taking their antihypertensive. And when it comes, so that it is now treated PRN rather than on a continuous basis. Because you actually cannot say, after taking it for a week, it will disappear. It won't disappear, it will come back. So you just manage PRN. Thank you.
Thank you, sir. Before you have your seat, there's a comment from one of the pharmacists. She said, what can you say about the use of tablet amlodipine being taken twice daily instead of once daily? Then there's another comment on the use of antacids.
Yes.
This comment says, kindly explain why antacids should be taken before meals. I thought it's supposed to be taken 1 hour after eating.
No, antacid should be taken on empty stomach. And if you have to take it, if the need arises, for you to take it after food, you have to allow 2 hours. If you take an antacid, before food, after food, you are also, there will be no proper digestion. Digestion will not, because you have, increased the pH of the stomach, and that will not go well for appropriate digestion. What's the need for the use of antacid is because of either dyspepsia or excessive hyperacidity. And when that happens, you have, to force balance. That's why I spoke of reset. You have to reset the stomach for appropriate absorption of either food or other drugs. So in the real sense of it, antacids are not, to be taken with food. They are to be taken on empty stomach. Otherwise, you also know the principle of antacid therapy, that they are not expected to be absorbed. They are just topical agents. They work in the mucosa without being absorbed, and they are passed away because they don't meet the criteria for absorption. That's why sodium carbenoxolone was withdrawn as an antacid, because the sodium was hyping, the blood pressure in people that have it. Now, most of them are inorganic substances, making them unabsorbable. And when that happens, you just need it for local effect to neutralize the acid and get away. So you don't need them with food. They will impair food digestion. The quality of acid will not be there. Okay?
Thank you very much, sir. Yes, there's no more questions for you. Thank you so much, sir. Dr. Ole, you will take this question on steady state. It says, steady state concentration in patients with impaired liver or kidney. How can we maintain steady state concentration and at the same time avoid drug toxicity?
Okay, thank you for that question. You don't have the same approach to all drugs. The first thing is for where you have an impaired liver, the first thing is to know if that drug is metabolized in the liver. There are a number of drugs that are not metabolized in the liver that are just excreted straight after their action in the urine. So if such a drug is not metabolized in the liver, you don't need to worry where the liver is compromised. You continue. But where the drug is extensively metabolized in the liver, what it means that if the liver is insufficient, it means that you will have more of the drug accumulating in the system, not cleared as usual as in normal person. And so you have to be able to determine the extent of that impairment. And that is done with calculation based on some parameters that you get from the liver function test. So you get the parameters from the liver function test, and you use that to calculate the extent of the impairment. And for such drugs too, in their monograph, they will tell you if it's a severe impairment, maybe you have the dose or you change to another drug completely. And if it is mild impairment, sometimes it does not affect the drug because it will still clear it, only that in a longer time. And same thing applies to kidney. You measure the kidney impairment through the renal function test, where you determine the level of creatinine and urea in the blood, and use that there are formulas. They are on the line that you can use to determine the extent of impairment. The first thing to do is the extent of impairment, and then to know whether the drug is metabolized in the liver or not. Of course, the major site of excretion is kidney, number one, and then secondarily, you have the liver. So if a drug is not metabolized in the liver, it means that the excretion is from the kidney. So if the liver is diseased, you don't need to worry about such drug. But where the drug is extensively metabolized in the liver, you need to determine to the extent of the impairment of the liver, and also determine from available monograph and information whether that degree of impairment requires dosage adjustment. And what you need to adjust is given there. And when you do not have it, you also have a question to determine that. So same thing applies to the kidney case. I hope I answered that person's question.
Thank you very much, Dr. Ole. So the last question is for Solagunju. How do we determine renal clearance from plasma creatinine so as to make dosage adjustments in renal compromise?
Yeah, please, can I say something just before Dr. Lagweji there? On the question on amlodipine dosing BD, okay. Can I say something there?
Yes.
Yeah, while I was making my presentation, I mentioned something like that. Sometimes you find out that, because I've seen patients like that 5 milligram amlodipine is not enough to control their BP. And then when you go to 10 milligram, they have side effects. Yes. So what we now do is to toggle that steady state concentration by now giving 5 milligram BD. When you give it 5 milligram BD, when you do the calculation, if it's a physical class we will have shown you, you will find out that the dose you will get at the steady state is higher than 5, but not up to 10. Yeah. So that way, the patient will avoid the side effects at 10 milligram, and we get something higher than 5 that can control his BP. Thank you.
Thank you very much for the questions on the creatinine. Of course, when you look at the GFR, most of the time, they use creatinine clearance to estimate, they use it to estimate the GFR, like in most cases. So there is formula for all these things, and I just also so that you can use it in the, because the renal disease is relative. It depends on the stage the patient in a stage of the renal compromise the patient is. So, and the formula is tailored towards those particular stages, based on the determinant trial. So, and the appropriate formula for dosage adjustment, and most especially for patients who, for the drug that is treated by the renal system. And of course, talking about, in addition to the steady state question, every drug must reach their steady state. And that, of course, is necessary for efficacy to occur. But what is important is for such drug not to cause adverse drug reaction on patients whose organs are compromised. And that's where the dosage adjustment is necessary.
Thank you very much, Dr. Olagunju. And at this moment, we want to bring the webinar to a close. We sincerely apologize. We don't have enough time, or we don't have any more time for more comments from participants. But we would like to sincerely appreciate everyone that has made this webinar a success. We recognize fellows of the Pharmaceutical Society of Nigeria, fellows of West African Postgraduate College of Pharmacists, elders and leaders in pharmacy profession. We want to appreciate our mommy, Professor Femi Yewo. We sincerely appreciate our healthcare professionals, pharmacists, doctors, nurses from the diaspora and also here in Nigeria. We sincerely thank you all for participating in this webinar.